Hello ladies and gentlemen, and welcome to the USAN session at this year's BOWS meeting. My name is Declan Murphy, urologist and director of GU Oncology here at Peter MacCallum Cancer Centre in Melbourne. I'm joined by my co-chair, Dr. Brian E. Norris, a consultant urologist across the street here at the Royal Melbourne Hospital. We've put together, I hope, a very interesting session focusing on two themes that I think will be of interest to a BOWS and a USAN's audience.
Thanks, Declan. So first we'll focus on PSMA imaging and theranostics, as we have some of the best research coming out of right here in Australia, and we'd really like to showcase that to the world. And our second theme will be on the challenges faced on urology training during a pandemic. And we'll hear from an Australian trainee who did her fellowship in the UK and a British trainee who did his fellowship right here at Peter Mac. So we hope that you'll find it interesting.
But before we do that, we want to welcome the president of USAN's, Professor Prem Rashid, who has a message for you.
Hello and welcome to this joint BOWS-USAN session. I'd like to welcome you all and thank the conveners for the work they've put into this meeting. This session represents a long-standing collegiate and supportive relationship. I'm sure you'll enjoy it. It's an exciting program. Have a great day.
Thanks, Prem. So now on to our first topic, PSMA imaging and theranostics. Truly, I'm sure you'll agree, one of the really hot areas in prostate cancer today. We have a big interest in that here in Australia, and it's a great pleasure for me to invite my colleague, Dr. Renu Eapen, who's a consultant urologist here at Peter Mac, to speak to us about PSMA imaging and theranostics. Renu did a GU Oncology fellowship at UCSF with Peter Carroll and Matt Cooperberg, and is now doing a PhD based on some of the lutetium theranostic work here at Peter Mac. Let's hear from Renu.
Hello, my name is Renu Eapen, urologist here at the Peter MacCallum Cancer Centre in Melbourne. Today I'm very pleased to speak to you about two very exciting areas in prostate cancer, PSMA imaging and PSMA theranostics. Now, Australian researchers have done a lot of important work in these areas in recent years, and I am pleased to share with you some important updates in this short video today. Coming up, we'll first review the data for PSMA PET-CT for staging of prostate cancer based on a randomised trial that was published last year. Then we'll review the very fascinating area of PSMA theranostics. And finally, we'll look ahead to some exciting areas of development in PSMA translational research that I hope you will find of interest. Now, as many of you already know, the PSMA molecule is overexpressed in prostate cancer, especially in aggressive stages such as castration-resistant disease. Now, this has been known for many years, but it is only in more recent years that small molecule ligands targeting the extracellular component of the PSMA molecule have been developed and have demonstrated extraordinary utility for imaging prostate cancer. Here at the Peter MacCallum Cancer Centre in Melbourne, we have had extensive experience using PSMA PET-CT since 2014. Our cancer centre has considerable expertise in PET imaging, performing more than 12,000 scans a year, many of which are part of ongoing research trials. We currently have 4 PET-CT systems and a number of gamma cameras for SPECT-CT, in addition to conventional CT and MRI systems. We have a cyclotron on site, 2 hot labs, and a very experienced radiopharmacy team. Our uptake rooms have sweeping views of the city, creating a restful environment for our patients. We also have a purpose-built theranostic suite to allow the delivery of radioligand therapies such as lutetium PSMA. The first data on small molecule ligands targeting PSMA emerged from Heidelberg in 2013. We were very interested when we saw these first images, and we performed our own first gallium-68 PSMA 11 scans in June 2014. Here is our first patient. This was a 65-year-old gentleman with high-risk prostate cancer scheduled for radical prostatectomy. CT and bone scan showed no evidence of regional or distant disease, but his PSMA PET scan was quite a revelation. We were impressed by the incredible contrast and tumour to background ratio, but we were also struck by the findings. His primary demonstrated intense PSMA avidity and also revealed a small pelvic lymph node and what appeared to be a rib metastasis. Now, this was an experimental scan, so we proceeded with the standard of care based on conventional imaging. A radical prostatectomy was performed, and of course the patient had a persistent PSA, and the rib metastasis proved to be true. We never looked back from there, and we have done thousands of these scans since then. There are now a number of small molecule ligands targeting PSMA, the best known of which is 68-gallium PSMA-11, which was recently approved by the FDA in the US. Others include DCF-PYL, a fluorinated tracer, which we expect will also receive FDA approval in the next few months. We use both PSMA-11 and DCF-PYL here at Peter Mac, and in our experience, these are about equivalent. The message is, all of the small molecule ligands targeting PSMA are good, and whichever one you can access most conveniently will be a good solution for you. So clearly, for anyone who has any experience using this technology, PSMA PET-CT is an obvious challenger to conventional imaging. The convenience of a one-stop whole-body scan with striking tumor to background contrast ratio is certainly compelling. However, striking images are not enough evidence to change the way in which we practice. Therefore, in 2017, we started a randomized trial, the PRO-PSMA trial, to compare PSMA PET-CT with conventional imaging in men diagnosed with newly diagnosed high-risk or unfavourable intermediate-risk prostate cancer. The results of the PRO-PSMA study were published last year in The Lancet. The primary endpoint was accuracy, so we randomized 302 men to undergo either CT and bone scan or PSMA PET-CT as first-line imaging. Unless they had 3 or more metastases, these men then crossed over to undergo the second-line imaging with the other modality. The patient characteristics are summarised here, most typical of a population at risk of regional or distant disease. The management plan was recorded at baseline and following each line of imaging, and the reference standard for accuracy was determined after 6 months of follow-up. So what did we find? Well, we reported that PSMA PET-CT is 27% more accurate than conventional imaging. A sensitivity analysis showed that PSMA had superior sensitivity and specificity for the detection of metastatic disease and for pelvic nodal disease, and this was true for unfavourable intermediate risk as well as classic high-risk disease. And some of the secondary endpoints may interest you as well. Management impact was very profound in these patients undergoing PSMA, whether first line or after conventional imaging. Equivocal studies were seen in 23% of conventional scans, but only 7% of PSMA scans, and radiation dose was less than half in men undergoing a PET scan when compared with CT and bone scan, plus the convenience of a quick one-stop scan. We also embedded a very detailed health economic analysis into PRO-PSMA, the results of which were published in European Urology recently. This study accounted for various specific aspects of PET imaging, including variability in generator costs across all sites, number of scans per illusion, staff time, including for quality assurance, and so on. We found that PSMA PET-CT was actually less expensive than conventional imaging. Moreover, when we factor in the superior accuracy of PET imaging, we observe a significant societal saving for accurate detection of nodal disease and of distant disease. Now, of course, health economics will vary from region to region, but as any of you who have been here can attest, Australia is an expensive country. So this study in favour of PSMA should be of interest to funders across the world. We therefore strongly believe that there may be a strong health economic argument to supporting PSMA PET-CT in the UK for this patient population also. Of course, there are also some uncertainties with PSMA PET-CT. In particular, we do not know if the decisions we make based on the superior accuracy of PSMA are actually improving the survival of our patients or even the quality of life for our patients. However, the availability of more accurate data will surely provide us with better information to advise our patients about their treatment choices and options. So having talked a little bit about the value of PSMA molecule as an imaging target, let's consider its value as a therapeutic target, an area of practice called theranostics. Theranostics can be explained as follows. Here you see a PSMA PET-CT of one of our patients with metastatic castration-resistant prostate cancer. Having exhausted all lines of therapy, overexpression of the PSMA molecule in his extensive bone and visceral metastases means that we can visualize these mets using a diagnostic PSMA PET-CT. However, we can also target the overexpressed PSMA molecule by combining a PSMA ligand with a small radioactive molecule such as the beta emitter lutetium-177. This therefore is a highly selective form of targeted intravenous radiotherapy, as essentially the lutetium will be delivered to the most prominent sites of disease with the most overexpression of the PSMA molecule. This approach was first described as in a case report from Germany in 2015 and immediately caught our attention. We therefore set up a prospective phase 2 study to evaluate the safety and efficacy of lutetium PSMA in men with progressive mCRPC who had exhausted all other options. The outcomes of this landmark trial was published in Lancet Oncology in 2018. This was the world's first prospective experience of lutetium PSMA and clearly showed very impressive PSA and imaging responses with excellent tolerability. Here we show you 8 of our exceptional responders who discontinued treatment due to a complete molecular imaging response following their initial cycles of lutetium PSMA. In each panel, you can see the before and after MIP images of these patients with clearly some quite dramatic improvements. You can also see the significant reduction in PSA under each image. The co-primary endpoint was best PSA response, and you can see here that we really had very encouraging data, with more than 2/3 of patients having a greater than 50% reduction in PSA. When one considers that these men have exhausted all other options at study entry, with a mean PSA of 190 and a doubling time of 2 months, there certainly seems to be some significant oncological benefit here. Therefore, unsurprisingly, within a few months of us delivering our first lutetium PSMA back in 2015, having seen some amazing responses, we started planning a multi-center randomized trial. The therapy trial was presented at ASCO GU meeting earlier this year by my colleague Professor Michael Hoffman, with the full manuscript published in The Lancet at the same time. Men with progressive mCRPC following docetaxel chemotherapy were eligible for this trial. Patients also had to have PSMA-avid disease with an SUV max of greater than 20 and no evidence of discordant disease on FDG PET. 200 patients were enrolled and randomized to either receive cabazitaxel or 6 cycles of lutetium PSMA. These waterfall plots display the primary endpoint of PSA response of greater than 50%. Patients receiving lutetium PSMA had a 66% response rate compared with only 37% in those receiving cabazitaxel. This represents a statistically significant hazard ratio of 0.71 in favour of lutetium PSMA. These patients also had improved progression-free survival with a hazard ratio of 0.63 compared with cabazitaxel, and an improved objective response rate in favour of lutetium PSMA. And of course, as expected, patients receiving chemotherapy had significantly more grade 3 and 4 adverse effects compared to those receiving lutetium PSMA. This trial is important as it represents a first randomized study to compare lutetium PSMA with a standard of care treatment for men with mCRPC, and it demonstrates superior PSA response, improved progression-free survival, and improved objective response rates when compared with cabazitaxel, plus fewer serious adverse events reported, and improved patient-reported outcome measures in favour of lutetium PSMA. Therefore, we conclude that lutetium PSMA represents a new class of effective therapy for men with progressive mCRPC. Now, the therapy trial has not yet demonstrated an overall survival benefit, but this is a secondary endpoint which will be reported in due course. We eagerly await the presentation of the VISION trial at the upcoming ASCO meeting, a trial of men with progressive mCRPC who were randomized to receive lutetium PSMA or best standard of care and has met its primary endpoint of improved overall survival. Finally, let's consider what's next for PSMA theranostics in prostate cancer. At Peter Mac, we have a large portfolio of ongoing prospective trials in PSMA imaging and theranostics. We currently have 2 trials to evaluate lutetium PSMA in less advanced stages of prostate cancer. The first of these is the Upfront PSMA study for men with de novo metastatic hormone-sensitive prostate cancer. This is a multi-center phase 2 randomized study comparing androgen deprivation therapy and docetaxel as standard of care, with ADT and docetaxel combined with 6 cycles of lutetium PSMA in the experimental arm. Upfront PSMA opened in the middle of the pandemic last year and is recruiting very well. And the other trial, which I think will be of particular interest to urologists, is the lutectomy study. We all know that men with high-risk, apparently localized prostate cancer have high rates of biochemical failure following surgery or radiation alone. And unfortunately, no neoadjuvant strategy to date has been shown to improve outcomes for these patients. We therefore designed this phase 1/2 study to evaluate lutetium PSMA prior to radical prostatectomy in men with high-risk prostate cancer and high SUV max on PSMA PET-CT. Professor Declan Murphy is a primary investigator in the study. The primary endpoint is dosimetry, with key secondary endpoints including safety and various oncological outcomes. I can tell you that we are very encouraged by our early experience in these patients. Here is a typical example of a 57-year-old with locally advanced prostate cancer, PSA of 38, grade group 5, PIRADS 5 lesion, and node positive on PSMA PET-CT. He received a single cycle of lutetium PSMA 6 weeks prior to surgery, with his PSA dropping to 4 and an almost complete response in his bulky external iliac lymph node on PSMA PET-CT. Surgery in these cases so far is extremely straightforward, with no treatment side effect in any cases so far, and perhaps even an improvement in surgical operability and resectability. We'll present interim results later this year. An exciting part of the lutectomy trial is our PSMA translational research, comparing pre-treatment core biopsies to post-treatment radical prostatectomy specimens. Samples will be interrogated to understand the immunological changes in the tumour microenvironment in response to lutetium PSMA treatment. We aim to address several questions about the changes in immune context, cell types, spatial interaction, and immune gene profiling. Our hope is that these findings from our translational work will inform future projects and lead to the development of effective radioimmunotherapies and combination therapies for high-risk prostate cancer. So as you can see, there is lots of exciting work happening in PSMA theranostics. I do hope that you find this topic to be of interest, and I'm looking forward very much to our expert panel discussion. Thank you.
Well, thanks very much, Renu, for that fantastic talk. And here we are with our panel in the studio. Thank you for that fantastic state-of-the-art on PSMA imaging and theranostics. And we're joined by two very special guests. Here in studio, we have Professor Louise Emmett, nuclear medicine physician from St. Vincent's in Sydney, a world leader in PSMA imaging and theranostics, and you've contributed some of the most important literature. So thank you for joining us today, Louise.
Oh, pleasure, Declan. Thanks for asking.
And joining us on Zoom from the UK, Dr. Alistair Lamb, a urologist at Oxford University Hospital Trust and a previous alumnus of this hospital, Peter MacCallum Cancer Centre. Alistair, thank you for joining us.
Thanks for having me. It's a pleasure to be with you.
Thank you. And we've invited Alistair for a UK perspective, and also he has some prospective work going with his colleague, Professor Freddie Hamdy, in PSMA imaging. So I'd like to start really by bringing you in, Alistair, and asking you, where are you in the UK with PSMA imaging for starters?
Yeah, thanks, Declan. It's a great question. There's been a lot changing over the last few years. So I would say, just my timeline, when I came back from Melbourne in 2016, there was very little PSMA PET imaging going on in the UK, really just one centre, UCLH, led by Jamshed Bamanji, and we'd refer our patients down there. But various other centres since then have acquired the ability, either with F18 or, as at UCLH, gallium-68. And I'd say there are probably between 5 and 10 centres now around the UK, including ourselves in Oxford.
And at the moment, only done within the context of trials, or is it a compassionate access programme, or who do you send in your centre for a PSMA PET-CT?
Yeah, we're very broad now in Oxford. We use it for all primary and secondary restaging. In the place of where we would have done cross-sectional imaging, we follow the results of the PSMA study.
Wow, that's quite encouraging to hear. I hadn't quite realised that. Here in Australia, Louise, of course, there's been sort of unfettered, almost wild access to PSMA PET-CT for 5 or 6 years now. What's your take on where we should be using it, having heard us about pro-PSMA and so on in the initial staging setting?
Well, it's interesting timing at the moment because we're going for funding for a rebate in Australia for both staging and biochemical recurrence, and I think ProPSMA showed that so nicely that we should be using it in intermediate and high risk patients going for surgery, so for staging. And in biochemical recurrence, we're obviously using it extensively in Australia, and I think it's really good at triaging patients as to whether they've got distant disease or whether it's still confined within the fossa. So biochemical recurrence and staging both, I think it's extremely useful.
And have you any thoughts on the different small molecule PSMA ligands that we have available? I know you have experience with using not just gallium PSMA, as Alistair said, and as we did in pro-PSMA, but what about the fluorinated tracers? Does it matter for viewers out there if they have access to F1007 or DCF-PYL?
I think if you've got a PSMA ligand, then it doesn't matter which one you use. I think they're pretty equivalent. You know, people have done head-on comparisons and really not found much difference between the two. Minor differences, but not really any difference at all. I think it's what you've got access to. We've got a lot of access to gallium here. Some people have fluorinated. Fluorinated's definitely easier to export distances. So, and I think we'll see a lot more fluorinated PSMA in the future. But if you've got it, use it.
Whichever one.
Yeah, whichever one.
So, Renu and Alistair, one of the key questions that arises from pro-PSMA, as we heard already today, is about the management impact, Renu. So, although pro-PSMA showed that PSMA imaging was superior in terms of accuracy, and it had a big management impact, how do we establish that the management impact is actually going to improve the outcomes for patients?
Yeah, that's the tough question, isn't it? Because even though we do use it a lot based on its superior accuracy and the management impact, we don't know if that equates to improved survival down the track. And you know, these are sort of harder endpoints in prostate cancer that will take years to really establish. And although overall survival wasn't a primary endpoint in the trial, it's a secondary endpoint. And I think within time, that data will make itself more clear to us.
Alistair, what are your thoughts on that? Is this a question that you face? Do people say, why are you using this scan when we haven't shown that it actually improves outcomes? It seems sort of intuitive to us that if you have better information, we can advise our patients better. Do we have to prove that, or can we just take it as one of these, surely it must be true?
No, I definitely think we do need to prove it. It's a huge headache, Declan, since we moved, and this is at Oxford, to using PSMA PET for all of our primary staging. To every man in who we performed an MRI marrow in the past, that's how we used to do it. We now do PSMA PET, so grade group 3 and above, all of them. And we just don't know what to do with the data. It's a real problem. We love the extra resolution that we get from PSMA PET, but of course, classic examples being these occult small numbers of pelvic nodes. I think we're reasonably comfortable now to deal with the single rib lesion, particularly with F18. We can disregard that, but those small number of nodes in the pelvis, possibly a single pelvic bone lesion, we just don't know what to do with that. And it's now dominating entirely our MDT discussions. They're fascinating. I've learned from you how to run an interesting MDT, but we don't really know what to do, and I think we need the data, and we're hoping to run a trial along those lines, led from Oxford, and love to have collaborators on that.
Yeah, look, and as you point out, it takes years and years. We can't wait for a 15-year endpoint. It's going to have to just be embraced in clinical practice. I think that's what patients expect, certainly. They like the accuracy. While we have you, Alistair, you have an interest in Oxford in radio-guided surgery, PSMA radio-guided surgery. Can you tell us a little about your work in this area?
Yeah, thank you. This is the PROMOTE study that Declan's referring to, which is use of radiofluorescence-guided imaging intraoperatively. We're just starting the second phase of that study, which is the randomized component, randomizing men to use of or not fluorescence-guided imaging for those with high-volume disease, where we may or may not be willing to undertake a nerve spare to assist in resection of residual disease. I'd love to tell you more when we're able to report our data.
Yeah, and I know Louise's group have an interest in radio-guided surgery, and we are about to start a prospective study. So that may be the new interesting dawn for us, is using the high value in this imaging and taking it into a radio-guided surgery context. The other area we want to talk about is theranostics, which was a very interesting part of your talk, and your PhD is based on this area. And Louise has a lot of experience with theranostics in advanced prostate cancer. So can I ask you about the lutectomy study that you referred to? This is a neoadjuvant study where high-risk men are getting lutetium PSMA prior to prostatectomy, and that trial's underway in here.
That's right. So I think our studies so far in theranostics have really highlighted the point that we should be considering this earlier in earlier stages of high-risk prostate cancer. And so lutectomy is really looking at giving upfront lutetium PSMA to patients who have intermediate or high-risk prostate cancer, and that's given about 6 weeks prior to surgery. And we're seeing if, dosimetry is the primary endpoint of the trial, but the secondary endpoints include things such as imaging response, biochemical response, safety profile, adverse effects, and of course, quality of life measures. So very exciting. We've recruited well despite the pandemic, as you know, Declan, your primary investigator on the study, of course. And we're hoping to recruit 20 men, and we're almost halfway there.
Yeah, so Louise, one of the things I love about these types of studies is it shows how we are embracing the nuclear medicine physicians in the prostate cancer MDT. You got urologists enthusiastic about using lutetium before prostatectomy. It might even put us out of business if it's that good, but,
Do you think it's really going to do that, Declan?
I don't think so. I wouldn't have done the study otherwise, but careful now. The title of the study, Lutectomy, was a provocative one from your colleague, Professor Hoffman. But it is interesting, and of course this year we've seen therapy coming out of Australia. We have vision coming out in a couple of weeks. So where are we going to be in a few months when people talk about radioligand therapy? What can we say for sure? Who's going to benefit?
Well, I think in terms of who can benefit, I think we can definitely say that people post-chemotherapy can benefit. So I think therapy has unequivocally shown a higher response rate to cabazitaxel chemotherapy in the metastatic castrate-resistant setting. Vision sounds like it's going to be positive. It's certainly been reported by the company as improving overall survival post-docetaxel in the metastatic castrate-resistant setting. So I think definitely in that space, and I think it's going to expand very quickly in Europe and the US once Vision is read out at ASCO. The really exciting thing for me is how can we prolong those responses and how can we make them even better. And I think, that Peter McCallum have got lots of combination treatments going on with you've got LUPARP, you've got PRINCE, we've got ENZA-P, you've got upfront PSMA, where we're trying to see whether we can both pull it earlier in the disease process and combine it with good synergistic drugs so that we get better treatment responses. I think we're really only just starting to see how good this can be.
And I think the fact that these positive trials, the two randomized trials in the post-chemo setting, will really give people more confidence to explore in these earlier settings. Whereas before it was, come on, show us some benefit. But OS coming in Vision means I think that we really will begin to see this. Alistair, any thoughts on this as we come towards a close? You have some access, I understand, to lutetium PSMA in the UK.
Yeah, you're right. It's not something we're so familiar with. Freddie Hamdy, Richard Bryant and myself, the sort of prostate cancer urologists, have teamed up with a basic scientist called Bart Cornelissen, who's been awarded a Prostate Cancer UK grant to investigate at a basic science level lutetium PSMA targeted therapy in preclinical models. So that's the sort of phase that we're interested in at the moment, but I think it's very exciting.
Fantastic. And with that, I think we're going to wrap up this panel. Thank you very much to Alistair Lamb for joining us from Oxford, and for Professor Louise Emmett, who happens to be in Melbourne for a couple of days working on your next phase of studies in collaboration with us here, which we're very excited about, both in imaging and in theranostics. And as ever, thank you for coming down to see us. And to my colleague, Dr. Renu Eapen, thank you for a fantastic talk. And it's really been interesting. And I hope our UK audience have found that interesting as well. We're going to swap over now, and I'm going to hand over to Bryony to introduce the next panel. Thank you. Well, Bryony, that was a great first session on PSMA imaging.
That was very enlightening. Thoroughly enjoyed it. So now on to our second session. So first of all, we're going to hear from Dr. Sarah Azar, who is a consultant urologist here in Melbourne. She completed her fellowship training over at Southmead in Bristol. And then we'll also hear from Dr. Marcus Cumberbatch, who is a consultant urologist at Sheffield University Hospital and completed his fellowship training right here at Peter Mac. Thank you.
Hello from Australia, and thank you for giving me the opportunity to share with you an Australian perspective on what it was like completing a fellowship in the UK during the first wave of COVID-19. My name's Sarah Azar, and I was the Robotic Pelvic Oncology Fellow at Southmead Hospital from March 2019 until 2020, and I was fortunate to be part of a unit led by Mr. Salah Al-Buhesi, and I was taught by Mr. Anthony Kuparis, Mr. Ed Rowe, Professor Raj Prasad, Mr. Jonathan Aining, and Mr. Raj Pal. And this is Southmead Hospital, and it is a shiny, new, beautiful hospital on the outskirts of Bristol that certainly looks different to most of the NHS hospitals that you see walking around central London. Here is the entrance foyer, and this atrium is actually 280 metres long. I couldn't believe my eyes when I first arrived at Southmead. There is actually a volunteer-driven mini train that takes frail patients from the front of the hospital all the way to outpatients down the back, just because the walk takes them too long. And I remember being overwhelmed by the colour-coded areas and the number of gates and levels, and presenting to theatre, asking for the robot theatre, only to be told there were actually 24 theatres across 2 levels in the hospital. And this is one of our Da Vinci robot theatres, and it truly was a joy as the robotics fellow working with the same team every day. I mean, these nurses knew everything about fast patient turnover, setting up all the different robotic operations, but also every surgeon's preferences and their favourite sutures and different setups. And here you can see one of our surgical assistants. This is Bayer, and the surgical assistants were just a wealth of knowledge, and they especially made me feel so welcome as part of the robotics team. Around mid-January 2020, I received a message from my husband back in Melbourne asking me whether I'd heard about a virus coming out of Wuhan in China and whether anything had changed at work. So I sent a private message to an infectious diseases physician at Royal Melbourne Hospital, and the reply was, at this stage we're not worried, but we now know things were completely different in Europe. I mean, by the 29th of January, British Airways had shut all flights or suspended all flights to and from mainland China. And we had our first COVID death by the 5th of March. By the 14th of March, there were 1,140 UK cases and 2 NHS deaths on the 25th of March. And certainly by the 17th of June, the death toll had surpassed 40,000. So what was Southmead's approach to all this? Well, in the first instance, there was a pause put on most elective surgeries with all other hospitals while units prioritised cases. And swiftly, it was introduced that pre-op patients had to have a COVID test 24 hours before surgery. We reduced our robot lists from 3 cases a day to 2 per day in each theatre, and a green COVID-free ward was created for post-op patients. A lot of our junior staff were deployed to either COVID wards or ICU wards, and this had a huge effect on our day-to-day rosters, which were constantly changing. And this was especially because every few days a registrar would either develop symptoms or report that their partner had COVID or was symptomatic, and then they would need to go into quarantine. So the fellows did more on call and helped cover ward duties as best they could. But the whole time the consultants did their best to protect our operating time, especially in robot cases. The bladder cases and the high-risk kidney cases were given priority, and the prostate cases received androgen deprivation therapy for around a month, and then they were able to be allocated to theatre lists. Our cystectomy numbers most certainly increased, and in the second wave, things were far worse, but no juniors were redeployed, so the unit could continue to run, and the prostate cases were actually completed in a timely manner. The radiotherapy spots for bladder cancer reduced, and so again, the number of robotic cystectomies increased significantly. But we all know that compared to London, Bristol certainly had far less cases of COVID. And in this graph by Liu et al., you can see that the cumulative number of cases in London is demonstrated in orange, while the southwest is down here in green. Over time, the percentage of weekly tests that came back positive was certainly far lower in the southwest compared to London. So what did my Australian colleagues do across the UK in Reading and Surrey and in London? The main challenge they all shared with me was the juggling of rostering and on-call as more doctors became unwell or their partners became unwell. Ward rounds and services had to be restructured to keep doctors either in the COVID-free or the COVID zone. And if they needed to move between these zones, then they had to shower, which was very time-consuming. In this unfamiliar time, even the consent process changed, as patients were actually counselled on the risk of contracting COVID if they came into hospital for their elective surgery. As a result, many patients were managed remotely, especially before transfer pathways were arranged, and often patients presented late or more unwell because they were trying to avoid coming into hospital. This is one of my colleagues, Nicola Jeffrey, she's a urologist in Sydney who completed a 2-year reconstructive urology fellowship at UCLH. Nicola was the fellow representative, a role which at first involved the odd meeting or an email, and it suddenly went from that to having to navigate the ever-changing landscape and provide support for fellows and junior staff. Nicola described this time as a huge learning experience. She told me, "I learnt the most I've ever learnt in the shortest space of time about non-technical surgical competencies." Suddenly she was managing stressed colleagues and keeping her team motivated, setting up remote meetings, and even helping set up emergency urology services. You may have seen this article written by Nicola and the team at UCLH in Urology News late last year about UCLH's involvement with the NHS Nightingale Hospital. Within 2 weeks in mid-March 2020, the Excel Conference Centre in East London was converted into a 500-bed ICU, and over 2,000 volunteers and staff trained to work in pandemic conditions. Now, they were not only doctors, they were from airlines and other healthcare professionals, and UCLH actually responded to their call for help. Although there was interventional radiology on site to insert suprapubic catheters, patients were coagulopathic and not all of them were suitable for suprapubic. So UCLH volunteered an on-call consultant and developed lesson plans and short training videos, even apps to teach the staff catheter care, catheter insertion, and difficult catheterization techniques. And here you can see Nicola teaching a small group about male catheterization. The consultants, the fellows and the nurses from UCLH delivered education sessions and pathways were actually written to troubleshoot difficult cases. The Australian fellows felt that this was one of the most rewarding experiences during their time at UCLH. While working on my unit, my consultants were always checking in on me. They knew I was in the UK without family, and they were worried about me contracting COVID or the borders closing. With their help, I was able to fly home. And back home in Melbourne, I was able to share with my unit how the UK tackled a number of challenges in theatre and outpatient clinics and on the wards. But even back in Australia, I worried about my colleagues and my patients as I watched the numbers rise again in the UK, and my mind couldn't help but drift back to my ward in Bristol. Working in the NHS, you cannot help but have the deepest respect for every hospital worker in the UK. We were busy and stretched before COVID, but this pandemic has caused us to work under the most extreme conditions. I know that all the Australians who completed a fellowship in the UK are forever grateful for the exceptional robot training that we received, the trust our consultants had in our skills to allow us to do their cases, and the help we had safely getting home. The NHS and the UK will most certainly forever be in my heart. Thank you.
Welcome everybody. My name is Marcus Cumberbatch, consultant urologist in the UK, in Sheffield. And this is a presentation all about my time on fellowship in Melbourne, Australia, and how the pandemic affected it. So the first thing I would say is when embarking on any fellowship, plan well. Contact a friend or a colleague who's done the fellowship recently or who's currently in situ and find out all the checklist items that need to be ticked off along the way. Medical registrations and immunizations. It all comes with a time lag and a cost. And when it comes to finances, take a tip from someone else again who's done the fellowship before. I did from Declan Murphy, and he put me in touch with the Royal Society of Medicine, and I was gifted around £10,000 through the Edison Cliff Foundation, which helped enormously. Focus not just on the sort of surgical side, but also on the things around it that can help you out. Find a daycare that's around the hospital or even inside it. This is one at the Children's Hospital in Melbourne, a fantastic unit with aquariums and meerkats. Of course, the pandemic meant that the kids didn't get to go to daycare at all times. And I was blessed by the fact that my wife was on maternity leave and could help look after our kids during the lockdown periods. Of course, you have to start the narrative early in the dialogue with your family before you go and get the buy-in that they are going to be able to support you and be happy making the journey across the oceans. And certainly saying goodbye back in the UK to family and friends was not an easy thing to do. If you can't find a donkey, find a grandparent. You're taking a lot of stuff most likely and you'll need help. There are such things as fellowship houses in inverted commas, where perhaps the furnishings have been handed down and bought and sold over and over again. And when you land at 5 in the morning after 20 hours flying, it's an absolutely fantastic thing to walk into a house with beds practically made, toys ready to go.
Welcome to Australia.
Don't make the mistake Jim Cato did and get a house without air conditioning in sunny Brisbane, especially when you might be spending a lot of time in it during a pandemic. When you get there, get an orientation around the building, understand all of the amenities quickly, and you have a richer start to your experience. Get involved in all aspects. Education and research often was able to continue with variations, but throughout the pandemic, lots of papers were written. Be mindful that the first month or so, you might not be the first surgeon. You might not get as much console time, for example, as you might have thought before you went, having been the top boy or girl in your own unit. But watching how other people do it may not be as stimulating as you'd like, but it certainly teach you how to avoid some pitfalls, and you'll start much richer. Get involved in the classes. We took great pride in teaching the locals how to play soccer. Make friends with fellow Australians or fellow people from the place that you're in. Certainly help you to learn all the haunts, develop new stomping grounds, and all the shortcuts. You'll make friends for life. We certainly did with our neighbours. And during a pandemic, having beers over the fence or driveway curries was absolutely fantastic. And whilst many things did stop last year, landmark papers continued to be published, and Pro PSMA came out and during my time in Melbourne, and it's something that I've taken home to Sheffield. My logbook didn't suffer. Over 100 prostatectomies and over 40 robot nephrectomies during my time there, including partials. And this is despite lists shrinking, but as a boutique cancer hospital, as Peter Mac is, I was fortunate that numbers pretty much carry on ticking along as normal. Be mindful that some things, even in a state-of-the-art centre, may feel old-fashioned to you, and you can help edify and build based on your experiences. Don't be afraid to take a back seat. Learn from the masters of the craft, even if they do support the Wrong Aussie Rules football team. It's a leap of faith going from registrar to consultancy, and the fellowship year really does build you up for that. You can be the best surgeon in the world, but you can still get sick, and protecting yourself and your family during the pandemic, incredibly important. Australia went hard and fast with restrictions, and whilst that was frustrating at times and meant we didn't get to gallivant around as much as we'd like to in the early stages, it meant that we were free to do so towards the latter parts, which was fantastic, and actually meant that we extended our stay for a while. Canvases became banana skins, anatomy lessons happened in the back garden, and much awaited parties had to happen on Zoom. Nonetheless, traditions continued, and we certainly indulged ourselves. I imagine many fellowship units are the same, but in Peter Mac, they really do look after you as a family and make sure that if you do get downtime, you spend it wisely. And we were off visiting all aspects of the city when we could. Friday afternoons became a real time for my wife and I to have some quality time together. And when we could, the checklist was ready to go. The buttons were ready to be pressed on the iPad, and we went to the highest mountains and to the longest beach, snow chains and all. And we became heavily invested in exercise. Apple Watches on the ready, lane swimming at 5 in the morning. We also got to do some bucket list items, such as seeing the Boxing Day test match at the MCG. Your sport for choice in a country like Australia, I imagine there are many countries the same. But we got a 17-year-old wagon and went off on our journeys through Queensland, Tasmania, and New South Wales. And the best thing about a pandemic for us, selfishly perhaps, is that when we got to everywhere, there was hardly anyone there. Tourists were void. Now, of course, many countries went through a lot of hardships during the pandemic. I'm not trying to make light of that, but just trying to show that actually every cloud has a silver lining. And we certainly took to food, coffee, and laughter as much as we could. And we certainly came back with some of the local lingo, and we were definitely better chefs for the experience. When you're in a lockdown in a pandemic, baking becomes the new watching TV. And the time eventually does unfortunately have to set on your time there, but you'll have made friends for life. And in some ways, you look forward to a new adventure going home. Now, sadly, the UK fared fairly badly during the pandemic, although their vaccination program has made for a turnaround. But when we look at 2020, we won't be trying to forget it. We'll look at it as one of the best years of our life, if not the best. And even the flight home, we benefited from the fact that there was hardly anyone there, sleeping in a way that benefited our energy levels. And when you get home, old stomping grounds are revisited, old trails are trodden on again, toys are refound. And whilst I grew as a person and as a surgeon, the kids also grew. Schools were started, nursery and daycare were started for the first times also. And catching up with grandparents and telling them about all the animals you've seen, the echidnas, the whales, fantastic experience. So in all, yes, of course, the year was different, but we were hungry when we could then to get out and about and made the most of every opportunity. Maybe spent a little bit more than we planned to, but we're richer for it. Thanks for listening.
Well, thank you, Sarah and Marcus, for those brilliant presentations. Gosh, what challenges you both must have faced, but I tell you what, it certainly looks like you had a great experience. We're joined now with our speakers and also two very special guests. We've got Lydia Johns-Putra, who is the chair of training for the Victorian section, and also Mr. Ben Chalicum, who is a consultant urologist at Guy's and St Thomas Hospitals in London. So thank you all for being here. I guess just a couple of questions. So this, to Lydia and Ben, how did you find the logbook progression of the trainees under your tutelage with regards to case numbers and everything during the pandemic? Do you think that it's going to result in any trainees needing to extend training?
I'm happy to jump in there, Bryony. So, as you know, Victoria was the hardest hit by COVID in Australia. The training experience was quite variable. Most hospitals managed to outsource their operating to private hospitals, and many trainees could go along and do that. Some couldn't. And of course, most clinics ended up being telehealth or phones rather than face-to-face. Time will tell whether there's going to be a long-term effect. It does seem that so far most will be okay and we'll have a reasonable catch up with only a blip, but I'm going to reserve my judgment and see whether it all evens out in the end.
And Ben, what about the people coming to you for the international fellowship? Surely, I'd imagine that you have a lot of international fellows that would come. Has the COVID pandemic impacted that?
Yeah, obviously it's been hugely impactful here in the UK. We've been in masks every day for 15 months and PPE in theatres. It's quite frustrating, of course. But at the beginning, we operated in green sites, very isolated, full PPE, every case, gaps between anaesthesia and the operating itself, and mandated consultant-delivered cases. So that obviously was very impactful on the trainees. But we made big efforts to get them back online. So for the fellows, we were able to do more modular training, really focus on specific aspects of the cases. Of course, the private hospitals wanted all the consultants to do the work, but if you're on a dual consult, they can't tell who's actually operating, of course. So we were able to get some cases done, and on double case lists, we'd have one consultant case and then one fellows case. But the trainees working in andrology and functional continence, BPH, and most of the elective stone, they hardly had any training. I mean, less than 1/5 of their numbers. And that is going to be an issue. They may have to extend training for some of our registrars because of this. Obviously, everyone's very sympathetic. We're now doing more dedicated training lists to try and catch up. Some really innovative stuff. Sticking on 10 TERPs on a Saturday, doing 8 hydroseals in a row, and actually doing some things that will hopefully allow us to mitigate some of this. But it's obviously been a real huge challenge. Yeah, no, well, we had no robotic prostates for 2 months. So that was all at that stage, simulation. And actually you can, if you really focus on the training, you can get a huge amount out of reviewing a case with a trainee, going through things, focusing on it, on the specific modules of the case, the bladder neck, the anastomosis, the nerve spare. You know, you're going to give them half an hour of the case, but it's going to be brilliant training for that half hour. So hopefully it mitigated that a bit.
I definitely see a way forward with regards to surgical training, you know, the use of robot simulators and a hybrid sort of model going forward. So Marcus, whilst, you know, we were very fortunate here in Melbourne to have low case numbers, we still had quite extensive periods of lockdown. How did this impact on your fellowship time here?
Yeah, I think comparisons to the UK and elsewhere, not as much. Certainly clinics became telehealth, less face-to-face. The ward rounds and inpatient management became skeletal. I think abilities to help train registrars from a fellowship level was hampered. And that was something I was looking forward to enjoying because I wanted to grow and mature and lead. Surgically, there were downtimes for a few months where the caseload of especially lower risk disease were sort of reduced, and the benign cases, TURPs, and diagnostic things like TURBTs, but a lot of the majors persisted. And I think looking back at my logbook, I've fared quite well.
Excellent. That's really great to hear. So, and advertisement for fellowship training in Australia, maybe.
Yeah, but you know, I suppose one of the things that affects everybody, Bryony, is everyone was anxious last year. We all still are, aren't we? And I think being separated from family, taking your family on a fellowship to the other side of the world is not without its own additional stresses, apart from worrying about your clinical training. So I don't know, Sarah, how did you find that, being on the other side of the world, the sort of anxiety everybody felt during lockdowns, and especially being separated from family?
Absolutely. I mean, I went to fellowship alone. My husband couldn't move to the UK. He unfortunately has a business here. So he was worried that I would contract COVID and have no support in Bristol. And the consultants truly were worried about me. I mean, they were checking the borders of the UK. They were worried about me getting exposed to COVID patients, but also they cared about my logbook. So even to the extent that they changed our contracts. So they knew that junior staff were being deployed to the COVID ward. So they said, no, these international fellows, they're actually junior consultants. We need them to do the robot cases. And that way we were protected. And so even the prostate cases were delayed about 1 month. We focused on bladder cases, and you know, we were advised to increase radiotherapy for bladder cases. We just increased cystectomies. So there was still learning, but every day the consultants were checking in on me, making sure I was coping, and they ultimately went to management and helped me fly home.
Gosh. Wow, amazing.
Wow.
It's so good to hear that you had such excellent support.
Hey, let's not ask Marcus the same question, because I don't think he had as much support on his fellowship. Let's move on. Yeah.
We'll move on. So Lydia, you've been involved with lots of you know, exam preparation and everything for the trainees as well. How did the postponement of exams or the, you know, format of that, did that change during the pandemic?
Absolutely, it changed. So I think thanks to people being creative, innovative, and open-minded, once we collectively made the undertaking that the fellowship exam would proceed and selections would proceed, the people in charge of those ran with it. And so the fellowship exam proceeded. We just had one sitting, not two, but it was done in hubs with the assistance of Zoom technology and that sort of thing, which was an amazing undertaking. Similarly with selection interviews to get into urology, that was also done in hubs with Zoom technology. It meant, though, that you had to recruit a lot more urologists to come in and do things gratis, as we do, in various states and jurisdictions like New Zealand, but it went ahead with barely any hiccups. So yeah, that was.
And Ben, what happened with exams and everything over in the UK? Did they go ahead, or was there an issue in selection and in post-fellowship exams?
Yeah, the FRCS was postponed for one iteration last year. The whole exam structure has now gone online, but thankfully the last one, literally last week, is back in person, which has been great, because I think it's just much more of a fulfilling experience for both parties to actually be there and go through the real Viva.
It's so good. That's excellent to hear. Just one final question to all of our panelists, and again, thank you for being here. What do you see as the silver linings to come out of this, pandemic in regards to urology training?
So if I may speak first, I mean, as an academic, newly appointed consultant, actually, a lot of the meetings that we would normally have to harass and harangue people to attend and to try and find a room that everyone can fit into is not needed because of the Zoom and platform and Google Meet and Microsoft Teams. And I think that that's allowed for greater progress and acceleration of those sort of meetings. And I think even the MDT, whilst it's not as fulfilling to not see your colleagues, it's actually making it quite effective.
Oh, well, thank you. Well, we might have to wrap things up there, but thank you very much to our panelists and our speakers. That was a very enlightening presentation and discussion. So over to you, Declan.
Yeah, sure was amazing. Thanks so much. And I suppose I'm very heartened to hear all those personal support stories, because what we want trainees out there to still have the ambition to do fellowships. I'm sure our panel would agree with that. And just because traveling is more difficult now, I think we must still keep the ambition that we know fellowships, fellowships add value. And I think don't be afraid, plan your fellowship and go and take a great leap.
Absolutely.
So that's all we've got time for. Thank you to BAUS and USANS for asking us to put together this session. It's been really enjoyable. Sorry we can't be there in person, but it's been really nice for us here in Australia and New Zealand to be able to put together this session, which I hope you all enjoyed.
Thanks.